Well, hello, everybody. It's that time of year again, and we're up for some protocol updates. So the 2025 collaborative protocol updates are now available. And just like last year, there is a change log that's available on the Bureau of EMS webpage that identifies the salient and specific changes. Not nearly as many as last year. So I'm going to hit the key changes that you should know about. Frankly, whether ALS or BLS, this is all combined because there's relatively few changes. Within the protocols, there's still some cleanup of the language, some readability, fixed a couple conflicts that we missed and a couple of errors. But overall, what I'm about to hit are the key changes to the 2025 protocols, which you can start using as soon as you know about them. And from a quality improvement perspective, you must be using these protocols by July 1st of 2025. So the first change that's actually relatively big is in adult and pediatric cardiac arrest, regardless of what the rhythm is, that for ALS providers, we have established that you need to give a maximum of 5 doses of epinephrine. So after you've given 5 doses, you are done. You do not need to give additional epinephrine. So your protocols have been updated to reflect that. On the adult side of things, it's going to be 1 milligram IV or IO repeated every 3 to 5 minutes to a maximum of 5 doses. For pediatrics, again, it'll be 0.01 mg per kg IVIO. Of course, you're using your hand heavy and you're repeating it every 3 to 5 minutes to a max of 5 doses. Any additional epinephrine would be on medical control orders. And the reason for that is that there's increased evidence that suggests that there's really zero benefit of epinephrine beyond the 5th dose. In fact, the greatest benefit is probably after the first and second dose, maybe some benefit with a third dose. We've done a conservative adjustment to our protocols to reflect that there is essential futility once you have administered your 5th dose. So again, there's some data behind this. From now on, cardiac arrest management, you'll give 5 total doses of epi, and then you're done. A reason that you might want to consider additional epi is if you truly think that this was an anaphylactic event that resulted in the cardiac arrest. But I'll be honest, that's the only one that I can think of. And at that point in time, again, I'm not entirely sure about the benefit. You'd need to call med control to have the conversation related to that. For both adult and pediatric cardiac arrest, for ventricular fibrillation or pulseless ventricular tachycardia, your collaborative protocols now reflect what we've been doing in MilREMS for quite a while, which is vector change defibrillation. And so within your protocols now, officially, you have an added connotation that you may consider vector change for refractory shockable rhythms. And then in the key points, it really defines what that is. Again, many of you are already familiar with this, where standard defibrillation is our classic sternal apex pad positioning, and vector change is really where we're placing an anterior and posterior pad. That anterior pad is really in the same location that your apex pad is for your standard sternal apex pad positioning. And the posterior pad is really placed on the patient's left side of the chest, on the lower portion of the scapula, just to the left of the spine. And again, we want to consider vector change after we've already given 2 shocks. So if you've given 2 shocks, whether that's an AED and a manual monitor or 2 shocks with an AED, then we want to perform vector change because we can have increased success in converting that rhythm using vector change than from standard defibrillation alone. And we always want to do vector change before we apply the Lucas if we have already given multiple shocks, because obviously once the Lucas is on or any CPR compression device, you can't do vector change because you can't move the patient to be able to get that pad on their back. So again, this just codifies some of our local practice that we've been doing for a number of years now in concert with our ECLS or extracorporeal life support protocol. Another thing, mostly for our paramedics is in adult and pediatric arrest for either ventricular fibrillation or pulseless ventricular tachycardia, that we've added lidocaine as an alternative to amiodarone. So you need to carry only one antiarrhythmic. So you need to carry either amiodarone or lidocaine. And if you carry amiodarone, then it's, as it always has been, you're going to give 300 IV and you can repeat 150 in 5 minutes if that VT or VF persists. But if you choose to move to lidocaine, that's going to be 1.5 milligram per kilogram IV, and then you can repeat it again in 5 minutes. Some of you, as old as me, remember the days of lidocaine drips. We are not adding in lidocaine drips. It's really just going to be a bolus dosing of the lidocaine in the setting of cardiac arrest. So one or the other, dealer's choice as it relates to amiodarone or lidocaine. There is a fair amount of clinical equipoise between the two. Your anaphylaxis and allergic reaction, as well as your difficulty breathing for both asthma, COPD, and wheezing protocols, we cleaned up a couple of things. Nothing's really changing what you're doing. This is for both adult and pediatrics. Simply clarified that it is only CFR and higher that can use an auto-injector. But EMT and higher may use a syringe epinephrine if you are so equipped and trained. One of the challenges that we realized is that the language suggested that a CFR could use syringe epinephrine, and that is not the case. Syringe epinephrine can only be used by an EMT or higher if equipped and trained. The other thing that we included across all the protocols is the EMT's ability to administer albuterol alone or albuterol with ipratropium, otherwise known as Atrovent. And again, that's if you have it, if it is available. So again, just clarifying what many of us have been doing for a while, which is that EMTs can give albuterol alone or albuterol and Atrovent. Say that 10 times fast and you'll be as tongue-tied as I. All right, within the behavioral agitated patient protocol for both adult and adolescent, we've removed haloperidol from the formulary. It has relatively narrow indications, has a side effect profile that is not as valuable to us. And what we have done is we've added olanzapine under the medical control option. So this is an agency medication optional pathway. If your agency does choose to do this, they do need to notify the regional medical director. And I fully expect that we'll be developing some specific training on who and how olanzapine works. But the nice thing about olanzapine is that it is not nearly as certainly sedating as midazolam or ketamine is, and it also works really well in certain populations. So this gives you a med control option for olanzapine, either intramuscular or sublingual. Again, this is an agency-specific protocol if your agency chooses to carry it, and I'm sure we'll be developing some training related to it in the future. A great tool within our armamentarium. Also within the behavioral agitated patient protocol is just a comment under the key points that indicated that if the agitated patient goes into cardiac arrest, refer to the appropriate protocol and administer sodium bicarbonate under standing order for the paramedic. And the reason for all this is that if we have someone that is extremely agitated and they go into sudden cardiac arrest, the most common reason is that they are profoundly acidotic. And this is likely both a combination of a respiratory acidosis as well as a metabolic acidosis. So it is very, very important that we are effectively ventilating that patient in addition to providing CPR and regular cardiac arrest care, but also that there may be some benefit to early sodium bicarbonate. So this is not after you've finished all of your protocols. This is essentially first line within your management of the agitated patient that unfortunately goes into cardiac arrest. Pediatric bradycardia, just a couple of comments in here. This is for everybody, ALS and BLS, reminding folks to consider chest compressions for marked bradycardia with depressed mental status or respiratory rate. And again, that's consistent with our American Heart Association guidelines, right? If a pediatric patient's heart rate is bradycardic to their age, or and their mental status or respiratory rate are decreased, then ventilate them and start compressions. The other thing that we did within the pediatric bradycardia protocol for our ALS providers is we simply reordered epinephrine and atropine. This was actually picked up by one of our educators here in Milrems, that we before had atropine first. And in pediatrics, generally, epi is going to be our first line. So certainly, if we have a bradycardic pediatric patient, that's usually because of hypoxia, so we better be fixing that. But if you're moving to medications, epinephrine, 0.1 milligram per kilogram IV is going to be your first line dose for that. Cardiac adult wide complex tachycardia with a pulse. Again, we've added lidocaine as an alternative to the amio. So again, that just allows you for a wide complex tachycardia with a pulse that you could give lidocaine as an option. This is the one case where you can give a repeat bolus dose or an infusion. I'll be honest, most of our transport times are low enough or short enough that a bolus dose is certainly sufficient. If you do have the ability to give a lidocaine infusion, that would be an option as well, but only under med control guidance. For pediatric tachycardia, again, added lidocaine as an alternative to amio. So for all the paramedics out there, check with your agency, see if you're going to stick with the amio or if you're going to make the transition over to lidocaine. And if lidocaine, then just brush up on lidocaine. Your dosing is pretty straightforward. It's 1.5 mg per kg IV in an adult or a kid, and then any repeat dose is 0.75 mg per kg IV or IO in an adult or child. Within heat emergencies, just reminded and added the fact that we can apply cold packs to the palms and soles, right? Our palms and soles are highly vascular locations. And so we added palms and soles to the other locations, including the neck, groin, or armpits. Any type of immersive cooling that may be available on scene would also be very, very appropriate for this. It's really important when somebody has a heat emergency that we get their temperature to normal as quickly as possible. Under hypoglycemia, we simply clarify that the dose range of oral glucose is 15 to 30 grams and basically clarified some available sugar source options, including maple syrup as an example. So point being is, if you have oral glucose, great. In the end, there's lots of other sugar source options that are available and if present may be administered. Within the shock protocol, we used to have trauma-associated shock, which was in the trauma section of protocols. We renamed that and moved it to the adult hemorrhagic shock protocol because this really is a protocol for any type of blood loss, right? So this could be obstetric hemorrhage, gastrointestinal hemorrhage, or traumatic hemorrhage. And so it's simply moved. It's the same protocol. We did update two things though. Number one is we increased the tranexamic acid dose to 2 grams. It's as a bolus. So it's 2 grams IV or IO, but it's given over 10 minutes. And the reason it's given over 10 minutes is if you push it fast, you get hypotensive, which is usually not good for a person that's already in hemorrhagic shock, which is why you're using this protocol, right? And also expanded the indications for TXA to include obstetric hemorrhage in addition to traumatic hemorrhage. This is a really, really good evidence-based tool to help reduce blood loss in the case of obstetric hemorrhage, which is why we've done that, and we've changed it to the 2 gram bolus dose, which is pretty much the standard now across the system. So as always, we're still awaiting some guidance related to the use of in initiating blood products, and as soon as that's out, you'll certainly hear from us. But take again another quick look at the adult hemorrhagic shock and make sure that we're thinking about that, not just for trauma, but obstetric or even a GI hemorrhage as well. Within the amputation and musculoskeletal trauma protocols, we clarified that antibiotics can be given to both open fractures and amputations because, well, hey, if it's amputated, it's probably pretty open as well. We clarified that moxifloxacin is only for adults, so that's oral moxifloxacin, and pediatric dosing was added for cefazolin. Again, this is an agency optional protocol, generally is only being carried by some of our agencies that have significantly long transport times for this specific population and is again paramedic only. The last big changes are in the oxygen administration and airway management section of your protocols. We clarified that for EMTs and higher, that you can consider a PEEP of 5 centimeters of water titrated up to 10 centimeters of water when providing bag valve mask ventilation. Before, it was kind of ambiguous as to whether or not EMTs or even higher personnel could be able to do that. But we did add under medical control considerations, adding PEEP beyond 10 centimeters of water, obviously provided you're able to maintain the MAP greater than 65. So really, this just enables the fact that EMS, our BLS providers can start a PEEP of 5, and really that is physiologic PEEP. So if you have a PEEP valve on your bag valve mask, it should be set at 5 basically all the time. And that's really not going to cause any type of hemodynamic collapse or other instability. And you can certainly titrate it up to improve oxygenation, provided you have a really, really good mask seal. We did remove under the key points the requirements for a ViraFilter. That, as we passed the 5th anniversary of COVID, was something to very nicely remove from it. So that's not required. Most of us have not been carrying those for a bit. Most importantly is the iGel pilot protocol that many of you participated in is now no longer a pilot protocol. Under EMTs, a supraglottic airway placement. So in our region, that's primarily the iGel. If you are equipped and trained and authorized by your agency medical director, that can be placed in the adult cardiac arrest patient. And again, that is adult cardiac arrest patients only for the EMT to place a supraglottic airway. Now, with that being said, an important point within the protocols is now clarified that any provider, so whether you are an EMT or paramedic, when you place either an endotracheal tube or a supraglottic airway, that's an iGel, you must utilize waveform capnography for both initial and ongoing monitoring of the airway. So again, saying this again, if you do not have the ability to measure capnography, you should not be placing any type of iGel or supraglottic airway or endotracheal tube in the trachea. And so that is codified within our regional protocols. And hopefully you are all also aware of this. 2502, our regional policy identifying the minimum standards for invasive airway confirmation and monitoring, came out last month. And obviously this policy is fully consistent with our collaborative protocol language that capnography is required for both confirmation of ventilation with the device and continuous monitoring. That's it. Those are the big changes. So the vast majority of these are for our ALS providers. Many of them are related to agency optional. So again, agency optional is utilizing lidocaine instead of Ammiel, would be using olanzapine and utilizing TXA. I'm sure we'll put together some separate training on those for agencies that decide to start doing that. But as always, take a look at your protocols. Take a look at the updated protocols, look at the change log, familiarize yourself with them. HANTEVI will be updated within just a week or two of this release of this training update and this advisory. Make sure that you have updated your HANTEVI app. You should be using it on just about every call, but make sure you've updated it so the protocols within those update. And hopefully this will continue to push our care forward within this region. As always, I appreciate everything you do every day for the people we serve. Stay safe.